It's on?
You're good? It's just for the recording.
Okay. Right, that's all right.
Sure.
So, Rachel, when I saw you in the cafeteria, I didn't recognize you. Is your hair different than when I last saw you?
It's crimped.
Okay.
Yeah.
You sort of walked past and was like, wait, who is that?
You ready to go? Okay, if I could have your attention, please. Ladies, could I have your attention, please? It is my honor to introduce our speaker today. Dr. Ken Olive has taken over what I consider a significant job, and I would like to emphasize how significant that job is. I've had several jobs within the College of Medicine, but it has been my distinct pleasure never to have dealt as much as he's had to deal with the Liaison Committee on Medical Education, otherwise known as LCME. LCME is the one that guarantees, looks at, changes, enforces accreditation for our entire medical school. The last time I checked, the packet that he had to prepare for the last site visit was in excess of 300 pages. And he did 99% of it because the 1% that I threw in wasn't worth enough to even consider. So today he is going to explain to us why we are doing this, and I would like everyone to pay attention because it is important and will affect our future going forward.
Well, thanks, Dr. Jernigan. So this is not the most fascinating talk you're going to hear, but it's an important talk because this really is an important topic. So this is the title that Dr. Jernigan asked me to use for this talk, LCME, Why We Matter. And the we in this talk is you. It's why you matter, because this is not a solo job to get accreditation done. It's a team effort that requires participation at lots of levels from a lot of people. It requires participation from medical students, from resident physicians, to attending physicians, to staff. So lots of people are involved in this team effort. So I have no conflicts of interest regarding this topic. And I'm not going to discuss any unapproved uses of devices or drugs today. What I am going to do is I'm going to explain the role and the significance of the LCME. I'm going to outline the responsibilities of the OBGYN department in the LCME accreditation process. I'm going to talk about resident responsibilities for medical student teaching. And I'm going to talk about the importance of direct observation of medical students. So the outline we're going to cover is, why does accreditation matter? What is the LCME and what does it do? A brief overview of some of the high-level accreditation standards. Then we'll talk about policies addressed in those standards like student mistreatment, institutional educational objectives, the OBGYN specific clerkship objectives, the OBGYN required clinical experiences, the curriculum review process that we use, resident as teacher requirements, supervision of students, direct observation of histories and physicals, mid-clerkship review, grade turnaround time, and non-involvement in assessment and promotion decisions by those who have provided care to students. So a lot of stuff. So why does this matter? Well, accreditation of allopathic medical schools by the LCME is required for federal funding. So that means that federal grants require that we be accredited. For students to receive federal financial aid requires that we be accredited. And we have to be accredited for our medical students to sit for USMLE exams. So it's a relatively important thing. And there are consequences to not being accredited. So this is from the online newspaper for Missouri University, and you can see the headline, School of Medicine Accreditation at Stake. Report finds a history of misconduct. And one of their main findings had to do with student mistreatment. So they haven't lost their accreditation, but it's an issue they're in trouble over. So this is a recent one. This is from March of this year. St. Louis University is not a minor medical school, so it is actually on probation by the LCME. It's the only school in the country right now that's on probation by the LCME. Probation is a big deal because you have 2 years from the time you're put on probation to fix the issues or you lose your accreditation. And losing accreditation means basically you have to shut the doors. So schools can't afford to allow that to happen, and it does happen. So it's important for us to address it. We also don't want to have the headline even like this, saying that we're taken off of probation. So we don't ever want to go on probation. And we're fortunate we haven't been on probation. We've had warnings at times in the past with issues that we needed to address. So accreditation is a big issue. We don't want to end up in the headlines over issues related to accreditation, and we don't want to be at risk for faculty losing their jobs, for medical students being in a school that's not accredited and having to look for another place, and it won't happen because we're all going to work together to prevent it from happening. So here's what you want to see. This is from the LCME website, list of accredited programs, and you want to see your name here and that you're fully accredited and that you've got a next site visit schedule. And our next site visit is in the 2019-2020 academic year. We'll probably be late in the summer of 2019, early in the fall of 2020. But we are fully accredited. We're proud of that. It's because everybody has worked towards that goal. So the LCME is the body that's recognized by the U.S. Department of Education as the accrediting agency for MD medical programs in the U.S. DO programs have a different accrediting agency. It's jointly sponsored by the Association of American Medical Colleges and the American Medical Association, and it's been in operation for 75 years. If you go back 75 years, things were a lot different in medical education then, and while there are times we feel like we're jumping through hoops with respect to accreditation, medical education really is much better in the U.S. because of accreditation. So the LCME is not a nebulous entity, it's real people. It's comprised of members who are medical educators or administrators in medical education programs or practicing physicians. There are 15 people in that category. There are 2 public members who are non-physicians, and then there are 2 fourth-year medical students who are members of the LCME. So the purpose of the LCME is to conduct a peer-reviewed quality assurance process to determine whether or not a medical education program meets the established standards. It really does try and foster institutional and programmatic improvement. The goal of the LCME is to not shut any institution down. The goal of the LCME is to help the institution comply with the standards. It establishes the standards, and it requires that programs demonstrate that their graduates exhibit professional competencies appropriate for the next stage of training, which in the case of undergraduate medical education, the next stage of training is residency training, and that their education serves as a foundation for lifelong learning and proficient medical care. So here's where we are in the process. Our next site visit will be probably in the fall of 2019, and in the previous academic year, 2015-16, we went through a comprehensive review of the curriculum. During the current academic year, we've been developing implementation plans for curricular change, and in the next academic year is the year of report for when we do our self-study for the next site visit, this thing called the DCI, this data collection instrument. So we have to prepare the data collection instrument that describes our program for the next site visit as part of our self-study, and that description will be based on what happens in the 17-18 academic year, the year that starts in July. So this next year is important for us to do things well. Other pieces that happen, medical students play a role. Medical students conduct something called an independent student analysis, a required part of the LCME self-study. They'll start that in a little over a year. We'll convene an institutional self-study task force in the summer of 2018. In the fall of 2018, we'll begin assembling the data collection instrument based on data from the 17-18 academic year. And then in the summer of 2019, we find out who's coming, and the site visit will be scheduled later in the summer, early in the fall. So students have an important role in this, and Their role is to organize and participate in the independent student analysis. We usually have our body called the Organization of Student Representatives conduct the independent student analysis. We have students serve on as members of the self-study committees. And also when the site visitors come, they meet with groups of students. They meet with one group that's first and second year students and another group that's third and fourth year students. So students play an important role in the process. Residents play a role. Chief residents meet with the site visitors to specifically talk about issues related to residents as teachers. And residents also play a role by participating in student medical education, what you're doing now along the way in compliance with LCME standards. We'll talk a little bit about that. And faculty have a role by conducting the educational program in compliance with LCME standards, by participating in the self-study, so we'll be soliciting members to serve on those self-study committees, by providing data for the DCI, so we'll be talking to Dr. Ransom and Brandy regularly during that time, saying we need this, we need that. And then faculty also meet with site visitors. So we're not going to review all the standards because there's not time for that. So I'm going to talk about selected elements from these 6 standards. So we're going to talk about the standard that relates to the academic and learning environment. We're going to talk about the standard that relates to competencies, curricular objectives, and curricular design. The one that relates to content. One that relates to curriculum management, evaluation, and enhancement. One that relates to teaching, supervision, assessment, and student and patient safety. And one that relates to medical student health services, counseling, and financial aid services. Now, each of these standards has multiple elements under them, anywhere from 3 to 7 elements. So there are overall like 90-some elements in the accreditation process. So the first one we're going to talk about is element 6.3, which relates to student mistreatment. Remember that at Missouri University, that was one of the issues for which their accreditation was threatened, was student mistreatment. So the standard says that a medical school defines and publicizes its code of professional conduct for faculty-student relationships, that it has written policies that address violations of the code, and that it has effective mechanisms in place for prompt response to any complaints, and that it supports educational activities aimed at preventing inappropriate behaviors. So we have a policy, and it's found in the College of Medicine catalog, which is on the website. It's on page 98. This is just the beginning of the policy copied out of the catalog, and it says, we have a responsibility to foster the development of professional and collegial attitudes needed to provide caring and compassionate health care by all members of the community, including medical students, graduate students, resident physicians, faculty, and other staff who participate in the educational process. So we have a policy on student mistreatment. It's outlined in the catalog. And basically the policy deals with the fact that we want this to be a supportive educational environment, that students should be treated respectfully. They should be expected to participate in things that contribute to their medical education. They should be appropriately supervised, etc. Now, every year, our graduating students participate in something called the AAMC graduation questionnaire. Students across the country at allopathic medical schools do that. And there's a series of questions related to student mistreatment. And these are the categories of student mistreatment that are outlined, that are included in the AAMC graduation questionnaire. And so they range from things that are at the lower end of the spectrum of mistreatment to ones that are egregious. So public embarrassment is one. Now, we all recognize that we've done things over which we're embarrassed in public. I mean, I've done things that after the fact I say, boy, I can't believe I did that. That's really embarrassing. That's not what we're talking about. But when we're talking about a situation where somebody knowingly sets out to embarrass a student, their purpose is to embarrass the student. Their purpose is not to educate the student. Their purpose is to intentionally ask them about things they would have no knowledge of and to keep hammering them about why they don't know it. That would be an example of public embarrassment. If you ask an appropriate question and if you ask the student to examine a patient, how dilated are they? The student says 8 centimeters. You say, no, it's 1. Well, that's appropriate embarrassment if the student is embarrassed. On the other hand, if you say, you stupid student, I can't believe you didn't know that was only 1, well, that's moving into the mistreatment category. Public humiliation is just a different place on the spectrum. It's further along the spectrum. Again, where somebody has set out to intentionally embarrass a student for no gain. Physical harm is rarely reported in our system. Physical harm, either threatened or actual, would be things like pushing, hitting, shoving, throwing things at somebody. We all know that's not appropriate behavior. Being required to perform personal services. Now, this is personal services are unrelated to educational activities or patient care. If it's go look up the results of the chest x-ray on your patient, that's not being required to perform personal services. If it's I need the weed eating done around the edge of my lawn this weekend, that would be being required to perform personal services. If it's go get lunch for the team, that would probably be in the category of performing personal services. If the student wants to do that, that's one thing. But if they're being required to do that, that's another. Being denied opportunities for training based on gender, race or ethnicity, sexual orientation, or religion. Receiving lower grades for those same reasons. Being subjected to offensive remarks for those same reasons. Being subjected to unwanted sexual advances. Being asked to exchange sexual favors for grades. Or being subjected to negative or offensive behaviors based on personal beliefs or other characteristics. So all of these would be examples of student mistreatment. When we look at the graduation questionnaire, we don't do too badly compared to other schools. We wish the responses were zeros to all of these. They're not. The ones students usually report are embarrassment or humiliation. And there are usually 1 or 2 students per year that will talk about having been subjected to offensive remarks based on one of the categories discussed here. So the goal is 0. We're not there. But relative to national numbers, we're doing better on average than schools as a whole are. So how do students report mistreatment? Well, one thing is just to report it to the next higher level of authority above the perpetrator. So if it's, and these more commonly happen in clinical settings than they do in the preclinical settings. And the perpetrator is not always somebody that the school controls. Sometimes it's a hospital employee. It may be a patient who's doing this. So you can go to the next higher level of authority. So if a student's being harassed by a patient on the service, going to the senior resident on the service, that'd be a reasonable place to start. Going to the attending physician on the service, going to the clerkship director, going to the department chair, places that you could go for that. So beyond that, they could come to the Associate Dean for Student Affairs, Dr. Tom Quasigrove, the Associate Dean for Academic Affairs, me, and then someone we have designated in the college for relatively confidential reporting is Dr. Theresa Lura, who's in the Office of Academic Affairs. I've got an asterisk there, and I did say relatively confidential because there are some categories of complaints that by law are not protected. So if somebody comes in and complains of something that represents imminent harm to themselves or another person, that by law can't be protected. If people have repeatedly come in and made the same comments that are egregious about an individual person, there's a threshold where even though students have asked for anonymity, that has to be reported. You may be able to maintain student anonymity, but reporting is required. But a lot of times students say, I don't want anything done about this. I just want this on the record that this happened in case there's something else down the line that we need to have further conversations about. So Dr. Lura is a very good source for that, and she's highly confidential in that regard. And all of you students know who Dr. Lura is. So an example we had within the past couple of years is we had a student on the surgery service here at Johnson City Medical Center, female student, and one of the OR techs was behaving in a sexually inappropriate manner towards her. And she actually came to me that time and talked to me. And I talked to the chief medical officer, and the hospital dealt with it expeditiously. They investigated it. It had been observed by other people, and they basically let the employee go because it was pretty grossly inappropriate behavior. But student mistreatment is a topic we need to address. More importantly, we need to prevent student mistreatment. Another source for reporting, if the mistreatment has to do with one of these categories, is the ETSU Office of Equity and Diversity. You can not go through the medical school at all, but you can just go to the main campus if there's discrimination or harassment based on one of these protected categories. All right. The next standard has to do with program and learning objectives. So a medical education program has to define its medical education program objectives in outcome-based terms. So these are the medical education program objectives for the Quillen College of Medicine. We have to make these known to medical students, to faculty, residents, and others responsible for medical student education. So part of accomplishing that is I'm making these known to you today. So you have copies of these. And these objectives are not just supposed to be something written on paper, but they are supposed to be what drives our curriculum. Everything we do in the curriculum is supposed to relate back in some way to these objectives. We also have to ensure that the learning objectives for each course or clerkship are made known to medical students, to faculty, residents, and others with teaching and assessment responsibilities. So you guys that are residents, you're supposed to know what are the patient types that our students are supposed to see when they're on the OBGYN clerkship? What are the required procedures that they're supposed to do when they're on the OBGYN clerkship? So here are the OBGYN clerkship objectives. Gather a history and perform a physical exam from female patients and incorporate ethical, social, and diversity perspectives to provide culturally competent care. Prioritize a differential diagnosis following a clinical encounter for common problems in obstetrics and gynecology. Recommend and interpret common diagnostic and screening tests for common problems in obstetrics and gynecology. Create and discuss patient orders for common obstetrical and gynecologic conditions. So it's interesting, the first version of this I saw said in women, but appropriately write prescriptions for common obstetrical and gynecologic conditions. Document an encounter in the patient record, either written or electronic. Provide an accurate and concise oral presentation of a clinical encounter of a female patient in an in or outpatient setting. Demonstrate the ability to collaborate as a member of an interprofessional team in both inpatient and outpatient settings. Recognize a patient requiring urgent or emergent care, including acute abdominal presentation and obstetrical emergencies. Demonstrate knowledge of obstetrical and gynecologic procedures, including the elements necessary for informed consent and impact on patient. Perform the identified procedures under direct supervision. Demonstrate an understanding of systems-based practice and students' role in a culture of patient safety and continuous quality improvement. So those are the learning objectives for the OBGYN clerkship. You all should know that because they're in the syllabus, which you've had an opportunity to review. Hopefully you've done that. You all should know that because that's something that was covered in the resident as teacher session. And so you can appreciate that it's important. If you're supervising students, you need to know what it is they're supposed to be doing. And so they're supposed to be doing things to help accomplish these objectives. And then these objectives are all mapped back to the College of Medicine institutional educational objectives. 6.2 talks about required clinical experiences. And we're required as a faculty to define the types of patients and clinical conditions that medical students are required to encounter, the skills that students are to be performed, the clinical settings for these, and the level of student responsibility. So here's what we have for the OBGYN clerkship. This is on a couple of slides. So in this column, level of responsibility can be performed, assisted, or observed. And over here, inpatient, outpatient, or both are what the letters refer to. So students should assist or observe with fetal heart monitoring. They should assist or observe with episiotomy laceration repair. They should perform an evidence-based presentation. They should perform a history and physical, which is observed. They should assist or observe with a hysterectomy. They should perform writing a labor note. They should assist or observe with a laparoscopy. They should assist or observe with a low transverse cesarean section. They have a mid-clerkship review with the director. It's on this list, but that's Dr. Ransom's responsibility. Well, part of it is because the students have to do part with that as well. They should perform an OB note. They should perform a pelvic exam under anesthesia with consent. They should perform, assist, or observe with a spontaneous vaginal delivery. They should assist or observe with obstetric ultrasound. They should perform a KOH prep. They should perform a pap smear. They should successfully demonstrate suturing. They should perform a wet mount looking for group B strep and fetal fibronectin. So the students are aware of this. They get that list. They have a list they have to check off on. In fact, the ones that have already been in to see me for their Dean's letter interview for residency, we go over their list of procedures. And so John and Gordon say, well, I haven't done that because I'm on OB now, but I'll get it done. So. And it's important for residents to know that students need to do these things so they can help create the opportunities for students to have these. Standard 8.3 talks about curricular design, and it says that the faculty of a medical school are responsible for ongoing review and updating of content and evaluation of course, clerkship, and teacher quality. That we have to be subject to ongoing monitor, review, and revision of the curriculum by the faculty to ensure that it functions effectively. So we have ongoing curriculum review, and the way that happens is each course or clerkship submits an annual self-study. So Dr. Ransom has submitted an annual self-study on the OBGYN clerkship that goes to a review subcommittee. It's the third and fourth year review subcommittee that has both faculty and medical students on it. That committee reviews the data submitted, draws their own conclusions about the clerkship, how well it's working, the quality of it, makes recommendation to what's called MSEC, which is our curriculum committee. That stands for Medical Student Education Committee. And then, beyond the annual review, every 3 years, every course in clerkship undergoes what's called a comprehensive review. It's sort of a deeper dive that looks more carefully at things. So we have gone through a process of a 3-year cycle of review. We did a 4th-year comprehensive review of the curriculum in 15-16. In this year, 16-17, we've been planning on curriculum changes that we will begin to implement in the next academic year. So in some large strokes, here are some things that are going to be happening with curriculum change. One of the goals has been to move back the start date of the 3rd and 4th year to an earlier time. 4th year, the way it's currently structured, is a little challenging for students. They end the 3rd year at the end of June. Residency applications are due on September 15th, so that's like 2.5 months in there. They have to take step 1. If they're going to do away rotations, they have to try and get those in there before residency applications are due. So that 2.5 month period of time, students have repeatedly been saying, this is really compressed, we're really squeezed. And so in this process, the curriculum committee decided, let's try and move back the start of the 4th year to an early period of time. Of course, that means the 3rd year has to be moved back to an earlier period of time. And that has impact on the first 2 years. And so to accomplish that, we're starting with the first-year students matriculating this summer. They're going to start a couple of weeks earlier. They're starting in mid-July of this year. The changes in the 2nd year will occur the next year. But to get this migration of the 3rd and 4th years back to an earlier time, we have 1 year only. That's going to be a transitional year where all the clerkships will be shortened by 1 week to accomplish moving the start date back earlier. And that year will be not this next academic year, but the following academic year. So the students that are finishing up as first-year students now, they will have this truncated 3rd year where all the clerkships will be shortened by 1 week. And that's a period of time when we're going to be asking all those people that teach in the clerkships, the clerkship directors, faculty, the residents, to be particularly attentive to student education to make sure that students are not getting shortchanged by the fact that their clerkships are a week shorter. So every clerkship will be a week shorter in that 1 year only. And we're also instituting a longitudinal doctoring curriculum. We're trying to pull together courses that relate to clinical skills, professionalism, societal issues, ethics, and career development into one long course. So we're working on the Doctoring 1 course first. It will include elements that have been in our Introduction to Physical Exam course, our Communications course, our Profession of Medicine course, our Case-Oriented Learning course, our Career Exploration course will all be pulled together into one larger course this next academic year. All right. The next standard relates to preparation of resident and non-faculty instructors. And so the standard says, residents who supervise or teach medical students are familiar with the learning objectives of the course or clerkship, so we talked about those here today, are prepared for their roles in teaching and assessment. You need to have some basic instructions on how do you serve as a teacher and how do you assess student performance, that you're provided resources to enhance student teaching and assessment. And then an aspect of the standard I don't really care for, it feels kind of big brother to me, is we're required to do central monitoring of that. So we can't just trust Dr. Jernigan to say it's happened. Dr. Jernigan has to submit documentation to us that it has happened that we keep in a file, and we do. So you guys had that on July 22nd last summer. And so it should be done on an annual basis, and it's submitted to us, and we have a special place on the College of Medicine server that's called the Resident as Teacher file. And every clerkship has a file there with documentation of who was there and what was covered. So, Standard 9.3 refers to clinical supervision of medical students. So medical school ensures that medical students have learning opportunities with patient care that are appropriately supervised at all times to ensure patient and student safety, and the level of responsibility dedicated to the student is appropriate to his or her level of training. And the activities supervised are within the scope of practice of the supervising health professional. So you can't be on labor and delivery and say, you know, we know Scott was a PA. So Scott, you go in and deliver this baby and come out and let us know how it turned out. You can't do that. That's not appropriate supervision. I couldn't be there and go in and supervise because I'm not an obstetrician. I'm not qualified to do that. So students need to be appropriately supervised. There's some judgment involved in what that means, and that needs to be developed by consensus internally. There are probably some things you're comfortable letting students do with minimal supervision, and other things you want very close supervision for. And so if you have an intern who's not credentialed to do something on their own, they shouldn't be supervising a medical student by themselves in whatever that activity is. So medical students need to be appropriately supervised by people that are qualified to supervise them. And medical students need to have some autonomy and being willing to extend themselves. But if you're really in a point where somebody is telling you to do something that you think is not safe for the patient, that you know you're not qualified to do, you need to speak up. You need to ask for an appropriate level of supervision. Is that comfortable? No. I mean, will people think that you're a wimp because you're asking for this? Maybe, but that's okay. Any questions about that, appropriate supervision? Okay, the assessment system has to involve a variety of measures, including direct observation, for assessment of student achievement. And that includes acquisition of knowledge and core clinical skills like history and physical. So let's look at a little bit of information about that. So this is data from the AAMC graduation questionnaire. This is one of the things students are asked to report on. We have this for all the clerkships. So in the clerkship, were you directly observed performing a history, and were you directly observed performing a physical examination? And so here's data from OBGYN, and you can see that you stack up relatively well compared to national numbers for history and physical examination. The observed history part is a little on the low side. 85% is a number that site visitors commonly look at for this, saying, we'd like to see that 85% of students say they're getting direct observation of history and physical. And you're really close. Now, one of the things about this instrument is there are things that we know with certainty that happen 100% of the time that get reported at less than that. So one of the questions that's been asked in the past is, do you have opportunities to participate in service learning? And we, for a long time, have had requirements in the first year of the curriculum in the professional medicine course to participate in service learning. We never get to 100% on students say they're participating in service learning. So you could look at this, and Dr. Ransom says, I know every one of the students had this done, and it's not going to get up to 100%. Well, probably every one of the students didn't have it done. People slip through the cracks. So it's important to make sure that we're working on that direct observation, because that is one of the standards. Now, your clerkship does a good job of using different ways to assess students. So here's the grading structure for the clerkship. So 20% of the grade is based on faculty clinical assessments, and I think that includes resident assessment too, doesn't it, Dr. Ransom? So that should say faculty and resident. 20% is a written exam, 20% is an OSCE, 10% is on observed histories and physicals, so everybody's supposed to be having an observed history and physical. 5% is based on the student's evidence-based medicine presentation, and 35% is based on the NBME exam at the end of the clerkship. So this is a nice array of different assessment methodologies for the clerkship. Another standard relates to formative feedback and gets at the idea that if students are not doing well, they need to know early enough in the educational experience that they're not doing well so they can do something about it. And so what's expected in clerkships is that there will be formal feedback at the midpoint of the clerkship. And you all are doing a great job on that. So this is what students say on the graduation questionnaire. You can see the national number was 93% of students said they got mid-clerkship feedback. And you can see over the past few years anywhere from 95 to 97% of students. And Dr. Ransom is raising his hand saying, it's 100. What can I tell you?
Sign the damn forms.
Well, there would still be some who would say no. So, but it is important. It is happening. And so make sure you guys say yes when you answer that question a year from now. Another standard has to do with fair and timely summative assessment. That is, that students get their grade within a reasonable time frame after completing the educational activity. Now, the standard says that final grades are available within 6 weeks of a course or clerkship. But if you're in a 6-week clerkship, like OBGYN, and then you go to your next clerkship, say it was pediatrics, that's 6 weeks. You wouldn't be, if you waited 6 weeks, you wouldn't be getting your OBGYN grade until you finished your pediatrics clerkship. And we think it's probably not reasonable that somebody's already completed another clerkship before they get their grade. So within the College of Medicine, we've set the standard as halfway through the next clerkship, or 3 weeks. And that's hard to do. I've been a clerkship director before, and I appreciate the difficulty of that. But you guys have really done a great job this year. This looks at periods 1 through 4. So this is the fall semester of the current academic year. And this looks at the days to submission. So all of those are within 21. And the last period, December, you were just smoking. I don't know if Dr. Ransom cracked the whip or if it was Brandy who pushed on that. But the hardest part as a clerkship director of getting grades done is getting the evaluations back from faculty and residents. I mean, it's not hard to get test scores. It's not hard to get the OSCE grade in. It's not hard to get the EPM presentation in. The hardest part is getting the faculty and resident evaluations back. So the way that you can help Brandy and Dr. Ransom out is by getting those things done quickly. And I know it's aggravating to do them. I don't like doing them, but it's just part of what we have to do. Students need feedback to know how they're doing. They need to get it in a timely fashion. And you guys are doing a great job. We really appreciate the job you're doing there. So when you're assessing students, don't just say, great job, or excellent student. That's not really all that helpful to anybody. So be specific. You know, they arrived on time. They appeared motivated to learn. They performed thorough histories and physicals. They were a helpful member of the team. They interacted well with the nurses. Whatever it was, give something specific that's meaningful, because a lot of times you do just get great job and you feel like you're doing creative writing when you're the clerkship director and you're trying to put something meaningful together in the evaluation. And the evaluations from these clerkships are important because they contribute to the dean's letter, the medical school performance evaluation. So all those clerkship summaries are rolled into that. So they're important. If there are areas that need improvement or of deficiency, clearly document those. Document them with enough specificity so the student will know what they're talking about, and submit them in a timely fashion. And then avoid the Lake Wobegon effect. For those of you who don't remember Garrison Keillor and Lake Wobegon, that was a place where all the women were strong, all the men are good looking, and all the children are above average. So all of the children, unfortunately, are not above average. So please make sure that your reflections, your evaluations reflect that reality. We're not asking you to be out to nail students. We're just asking you to give realistic and appropriate evaluations. So the next standard we're going to talk about is the standard that has to do with non-involvement of people who provide care to students in their assessment. And so the standard says that people who provide health services, it used to say sensitive health services, now it says health services. So any health services to medical students, including psychiatric or psychological counseling, should have no involvement in the academic assessment or promotion of the medical students who's received those services. So if a student goes to see Dr. Sarkody as a patient, Dr. Sarkody should not evaluate that student when it comes time to do clerkship evaluation or any other evaluation. If they ask one of the residents to see them, the resident should not perform an evaluation on that student or participate in decisions related to assessment or promotion. So the way we address this is the first question on a clerkship assessment form is, have you provided health services to this student? And if the answer is yes, don't complete the rest of it. And also at the Student Promotions Committee meetings, one of the first questions on the agenda is, have you provided health services to this student? If so, you need to abstain from discussion and voting related to this student. So that covers the things I wanted to cover with you today. And the point I wanted to make is that you do matter. Every one of you matter in this process, because I have a lot of responsibility in this. I can't do this. I can't do the direct supervision of things I'm not qualified to supervise. I can't be out there doing direct observation of histories and physicals on all the students. I can't assess all of the students. I can't provide the data needed for all these reports. I can coordinate its collation and synthesis, but every one of you makes a difference. Medical students matter, staff matter, faculty matter, residents matter. And accreditation matters, because if we're not accredited, then all of us are going to be looking for other opportunities to pursue our careers. And I'm pretty happy here. I'd like to continue to stay here. So we'll work hard to make sure that the College of Medicine accreditation remains intact, and we need your help to make that happen. Any questions? All right. Dr. Ransom and Dr. Olson.
You know, I understand that all of this documentation has to occur, and the tick sheets have to be completed and so on, but is there any objective evidence to suggest the way things are being done now in terms of medical education are turning out better physicians than, say, 20 years ago, when we didn't have this kind of thing? It was much more of an apprenticeship, and yes, you were part of the education was the humiliation and the all of those things. I mean, have we given rise to a whole new generation of better physicians because of this swing?
So I can't cite any evidence that would document that's the case. So I think if you look historically where we are today compared to where we were 100 years ago, they were a whole lot better than we were. I had an occasion recently to look at the actual Flexner report, came across a copy of it. And when Flexner was doing his study, there were 14 medical schools in Tennessee at that time. Many of them had no standards for getting in. You didn't have to have a high school education to enter the medical school. They didn't have very many faculty or facilities. You paid your money and you came through. And you did your time and you got your diploma at the end of time. So certainly we're at a whole lot better place today than we were back then. But to answer your specific question, no, I don't know of any evidence that speaks to that. Dr. Olson.
The area of personal improvement for us is that I had no way of knowing if I saw medical students who were first year students. We just don't track that and I'm going to forget. So I guess our department probably needs to make a list or something.
Well, I think we would expect there to be a couple of places for that to come into effect. One is that students have some responsibility to say, you know, I saw you as a patient, so you really shouldn't be involved in my assessment on this clerkship. They also have a role to play by picking people other than us faculty members to see as patients, and we encourage students to see people other than those of us who are faculty. And you know, when you, I don't think we're going to get in trouble if somebody did not recall that this happened and evaluated a patient. But if you remember that you saw this student, then certainly you should. So I heard a case where somebody was really worried about this because a student came to them, they were a pediatric surgeon, and said, you removed my undescended testicle when I was 6 months old. You know, how are you going to make any connection there? So that's not...
What about delivering them?
Or delivering them.
Yeah. I've had that happen, so yeah.
How many of these, Dr. Jernigan? So, don't answer that question. So, Dr. Jerpy, do you have a comment? Okay. Any other questions, comments? Well, we appreciate what you do. You help make our accreditation possible, so keep up the good work.